here. And I want to welcome Lea Milgraum and Elisabeth Schuler, who are patient advocates, and they're going to tell us, we're going to get to know them. We're going to get to learn a little bit more about their profession, and you in the audience can ask any questions, make comments, what have you. So Elisabeth and Lea, welcome. I'm delighted we were able to put this together and spotlight your profession. Let's dive in and get to know the two of you a little bit better, and then we'll learn a little bit more about your profession and start engaging with our audience. So Lea, tell us a little bit about yourself and what led you to this profession.
Hi, thank you for having me. I'm glad to be here. I was born in Lithuania, which was then part of the former Soviet Union. And at the age of 8, we moved to Germany, and that's where I grew up. That's where I went to medical school. And as a young adult, I moved to London, worked a little bit as a junior doctor there, and then met my husband and came to America. Here I had to requalify as a physician again, and then I worked in pathology at Hopkins for a little while, and then I started residency in pathology at University of Maryland. But then we had children, and I really did not want to go back, and I just did not see how I could take care of my family and have that type of schedule that was required. And so when I had children, I actually went to school for massage therapy. I got a license in massage therapy. And then I went back as a PA in pathology. So it's a master's level job in pathology, and was able to also get certified in that. And I worked in that for many years at different hospitals in the area while we had more children. All these years, I was helping neighbors, friends, family. People would call me, well, how do I deal with this? What did the doctor say? What did they mean? Where do I turn? And I was wondered, how do people manage who don't have a doctor in the family? And so when I sort of tired of being a pathology assistant, I was looking for a different field, and I wanted to apply myself like this, but me too did not know that this profession existed until I finally connected with people and found people and realized that this is a way forward. And in 2019, I opened Harmony Patient Advocacy, which is my service. And I help people navigate the medical system. I help them find the care they need. Not the system is imposing on them. Finding the right providers, it starts either with, I have symptoms and I can't figure out what the diagnosis is, or I have a serious diagnosis and I need to know how to move forward. And always with every serious diagnosis, you need a second opinion. I can't tell you how many times the first opinion was not what the patient needed, not the right way to go.
Yep. No.
So anybody who has any serious diagnosis, any surgery needs a second opinion, at least a second. And if they disagree, then you need a third. And so I would find a specialist for the people, not just go to somebody to ask an opinion, but to find a specialist, preferably obviously in our area, and we have wonderful hospitals here.
Great. No, that's awesome. I love it, and we're going to dive into those details. So let's give Elisabeth an opportunity to tell us a little bit about what your background and what led you to starting your practice.
Thank you, Steve. Hi, everyone, and thanks for tuning in. Unlike Lea, who has a medical background, I do not have any medical training per se. I actually, my background is in diplomacy. I was a foreign service officer with the Department of State for 25 years. And the way, and Lea said she discovered this profession she didn't know existed. Well, I've been told that I'm one of the sort of pioneers and trailblazers in creating this profession. And the way it happened is that in 1998, when my family had just returned from an overseas assignment with the Department of State with Foreign Service, our 2-year-old daughter was diagnosed with an inoperable brainstem tumor. This was in September 1998. So pre-Google, early years of the internet. I was not going to take that diagnosis, which at the time was fatal. And I realized very quickly, this is not a universe I know anything about. I better get smart very fast. And I began doing the research and reaching out to doctors around the country. You know, I became her advocate. That became my job because there was no lifeline, there was no roadmap. Long story short, when I started my company in 2004, when none of this profession really existed, but I was still working at the State Department. So I moonlighted in my own business. And then I retired from state and went full time. And my company is Patient Navigator, LLC. We do a lot of the same things Lea mentioned, care coordination, medical research, advocacy, bedside or other. And the ending of the story is that my daughter just turned 25 3 days ago, and she herself is now a nurse at a pediatric nurse at Johns Hopkins.
Wow.
So
No.
life came full circle, thank God. And now I devote myself to helping patients and families find their way through our complicated medical system.
I love it. No, this is two great backgrounds, two great different backgrounds. And because, you know, the healthcare is one thing, but then the sort of the negotiation and standing up for yourself and advocating is another. And, you know, yesterday we featured a software platform that helps family communicate with. And I kind of stumbled into, in our discussion, the do-it-yourself health advocates, you know, which you described, Elisabeth, is that there's so much that we don't know. And when you're doing it yourself, you're learning along the way. And if you can just tap into somebody or that can help expedite that learning curve, that can be a shoulder to cry on, somebody to talk to, it can make things a lot better. So, all right, so we got to know the two of you. Let's talk a little bit about this profession of patient advocates and what it's all about. And then we can dive into some real life stories of how this has been applied. And then, of course, I'm going to lean on our audience to ask some great questions too. But I'm thrilled to spotlight this very important profession.
Well, I'll talk a little bit. I'm going to have an article published in November in the Journal of the Society of Certified Senior Advisors. So I'm going to talk a little bit from that draft, which I'm sure there are CSAs in who are listening, I hope. But literally, when I tell people what I do now, everyone has a story of when they were overwhelmed, confused, afraid, unsatisfied by the healthcare system, you know, an aging parent who's getting inadequate care, a bad emergency room visit, a scary new diagnosis, battles with the insurance company, the specialist merry-go-round, which we can talk about what that is, or doctors who are just dismissive. So, you know, the idea that patients need helpers or advocates has always been there. It's been a friend or a family member or a spouse. But I'd say the profession itself has really coalesced since 2009. It's becoming known much as, financial advisors or legal advisors have a place in managing life, a patient advocate now can have a place in helping people manage their healthcare. And like you said, this is not something you want to learn on the job. You don't want to figure it out as you go. You want someone who's been there, done that, knows the ropes, knows the system, knows where the landmines are. And so that's how this profession really came to be, is that it's people like me with completely different backgrounds, but through their own experience have come to it. It's people like Lea who have medical backgrounds, former social workers, former nurses, all sorts of people now realize I know how this works and I can help other people. So it's really a profession born of necessity, I think, because we have such a complicated, inefficient and expensive and often frightening healthcare system. I also want to run a couple of definitions past folks. So patient advocates are people like us. We work only for our clients. We have no insurance does not pay for private patient advocacy. And that's just not a thing. And we don't want that, because we want to work only for our clients. We're not beholden to any other institutions. Our code of ethics precludes us from ever taking money for giving out referrals or anything like that. Now, there are also navigators in hospitals, and that concept really began with breast cancer navigation and a doctor named Harold Freeman, but I'll save that for another topic. So in a hospital, you will also often find navigators, and their job is very helpful. It's to help patients during their interactions with that hospital system, whether it's to set up appointments, make sure tests get done, order medications, and to provide moral and emotional support. Hospitals also sometimes have what hospitals call their patient advocates, whose role is slightly different, and that's mostly to solve problems while the patient's in the hospital, so that no bad issues, are left unresolved to the patient's satisfaction. But for them, and the name of my company is Patient Navigator, which speaks more to the hospital approach. But I came up with this name in 2004 when none of this really existed. But to me, it speaks of what we do. We are patient, and we navigate people through this complicated system to help them find better outcomes and good resources. Some of the things we do, I'll just give you a quick checklist. And not every advocate does all of these things. Everyone sets up their practice however they want to. But for example, the things a patient advocate could help you with: disease research, insurance problems, finding doctors, understanding treatment and care options, preparing for and going with them to visits, quarterbacking the healthcare team, facilitating communication with family members, caregivers, doctors. This is very big, especially if you're an advocate for a senior whose adult children live elsewhere. Mobilizing resources, managing medical paperwork, and this is also, a lot of us do this, guiding through aging parent transitions. That's often a big part of our work. Gathering medical records, serving at the hospital bedside, and as you mentioned earlier, Steve, sometimes it's just enough to offer a soft shoulder to cry on. So that's just a range of things that you could look to an advocate to do.
This is great. Okay, let's see. And we've got a few questions or comments that have coming in. Somebody comments, that was a beautiful miracle story about your daughter. Thank you so much for sharing. Are you willing to share what happened with the tumor diagnosis and how you were able to choose faith and courage to turn a medical condition around for a different outcome?
May I answer that? Is that all right, Steve?
Oh,
I'd like to
absolutely.
answer it.
No, I want you
Oh,
to.
okay, yeah.
I'm curious about that as well.
Well, her tumor was in the brainstem, and we could not biopsy it because the location was too terribly dangerous. And I sent MRI scans in that back in 1998, the big, films around the country, and two other surgeons besides the local one concurred we shouldn't biopsy. It was too risky. The brainstem controls breathing, swallowing, all of sort of the reptilian functions. And so we took the only treatment that was available, which was radiation treatments. Chemos do not work on brain tumors, at least not in 1998. They don't cross the blood-brain barrier. And so we took this very risky treatment option, which was the only one available. And they warned us of all kinds of late-term side effects she might have. It was a miracle. And if anyone ever looks at my website, you will see in my story that I came to the realization I needed to do this work because I felt God had given me this incredible gift. And the rest of my life, I was going to pay back that miracle. And so we never know. I mean, we never knew exactly the pathology of the tumor. But what happened was 6 weeks of radiation. This is a 2-year-old. She had to be sedated every time. She used to go there in her Barney pajamas, and the tumor began to shrink. And over time, we had one little setback, but then over time, it continued to shrink. And in the subsequent years, it is now appears on MRI as a small piece of just a little necrotic spot. So so much of it was faith and a lot of prayers and a ton of research by me and many phone calls and determination and questions to doctors.
Yeah, and just
thank you for that question.
Now the value is that for those people going through these challenging situations, there's no guarantee of any outcome for any of us, but to just have somebody else that you can communicate with and you can bounce ideas back and forth on your behalf very objectively that is in your corner. Another question came in. How are patient advocates different from care managers?
Lea can speak to that.
So care managers do tremendously important work, and I refer people certainly to them. But what they cannot do is actually evaluate the medical care that their clients get. So they do all the important wraparound services of home health and assessment and what support do people need, and family support and family mediation. But when it comes to when mom actually goes to the doctor, what does he or she say, and how should they proceed? So I had a family actually recently. A gentleman called me about his parents, 83 and 90 something, and the mother has shoulder pain, so severe, and so I stayed on the phone when she went to the orthopedist. I listened to what he said, the options he presented. I discussed the situation before and after with the family, how to proceed. Should they see somebody else? Should they not? How much can you drag such seniors to doctors? Do you need to? Should you continue? Should you not? What can you expect? Is surgery an option anymore at a certain age? The risks become so great. Is this beneficial, even if it's an option? So this is something that a care manager really would not get involved with. This is intensely medical, that type of thing.
Okay. No, that's great.
Yeah.
Mike has another question that I think you sort of, as you were describing that, it popped into my mind as well. And he says, how are your services seen and accepted by medical providers, the doctors, the hospitals, and then by other family members other than the patient? And I guess when you talk about evaluating the medical, diagnosis or what have you, I imagine I think one of the challenges that we all face is we listen to the person in the white coat who's standing in front of us. If it's our internal medical, person, if it's the doctor in the hospital, it's like, well, I got to do what they say.
Right.
But do some of these doctors, if you're sort of evaluating, how are you working with these other providers?
I think we'll both want to take a crack at that. It's a great question.
No, this is great. No, that's what we want.
Yeah.
And
Okay, you
I know
can go
that's what
first.
Mike wants too.
It has evolved. When I first started doing this, in 2004 and then full time since 2009, people had no idea who we were or what our role was and wondered, like, why are you here? And so it's very important from the outset to make it clear this is not at all an adversarial thing, that we're on the same team. We have the same goals for this patient. We are there as another set of ears, eyes, note-taking, asking questions, because it is absolutely true, and especially with seniors, that you get in that room with the white coat and you freeze. A lot of people just freeze up. This used to happen with my mother-in-law in New York. We'd call her, what happened at the doctor today? What did he say? Well, I'm not really sure. I think everything's fine. I mean, that's typical. And so at least I, but I think I speak for most, we explain our role as we are a member of the care team. And we never diagnose anyone. We don't try to diagnose. We provide information and reliable, credible research. We don't jump to Dr. Google, which is like the worst thing you can do. And so older doctors sometimes are very puzzled and not so keen on this, but younger doctors totally get it, because younger doctors understand that in this day and age, patient-centered care is what patients demand. And now with the free flow of information on the internet, for good or worse, I mean, if you get good information, it helps. They expect to be listened to and to be heard. So we explain our role as, helpers, members of the team with the same goals. It's never portrayed as an adversarial thing. And the thing about, treatment options and information, you just are mindful of, we aren't Lea's an MD, but most of us are not MDs, and that's not our role as advocates to be MDs. So, we're respectful, we're judicious with the time we take. We only bring reliable information if needed. And so I think more and more as the profession is becoming known and people have experience with advocates like us, they're more welcoming and see that we do have a place in the picture.
Yeah, well, what's interesting is you were talking, and Lea, I want to get your thoughts on this topic as well, but I don't know the exact phrase, but it's something about, like, if you ever have to go to court, never go into court without an attorney, because the attorney knows how to speak the language of the court.
Exactly.
And I think that basically our medical system is probably way more complex than and not universal in nature as our court system, but we sort of go in and we're alone in there, and we're sitting there at our loved ones' bedsides on our phones trying to get that education. And the analogy of attorneys in court and a patient advocate in the healthcare system, for me, resonates.
Yeah.
Lea, you want to share your thoughts on this? And then I also want to make sure that we share with our audience the different trade associations and certifications where they can learn more about your profession.
Yeah, I used a simple example of going to a car mechanic. when a car mechanic tells me I need this or that, I just look at him blankly and I say, okay, if you say so. I don't know. Do I need it? Do I not need it? I have no idea what you're talking about. And that's it's not my life.
Yeah.
So even if people don't freeze, often doctors will just not even realize how they're talking medical language, and to make themselves understood would require so many hours that they don't even try often, because they know this is just not going to go anywhere. How do you explain cancer if people don't even know how many livers they have? It's not possible. So yeah, and with acceptance, in hospitals more and more there is education of the staff that if you say you are in Hopkins, I think they call it now care buddy, you get put into the chart, and then you can just refer to it. I'm in the chart, you're allowed to talk to me, I'm representing the patient. And in the relationship, very quickly physicians learn, even if they're skeptical in the beginning, how helpful you are. You save them time. If the patient asks a question, and then I can sort of say, yeah, we'll talk about it later, because this might not be relevant, or not be this, or not be that, and it just doesn't matter. But also I can ask questions the patient doesn't even know to ask, and we can have an intelligent conversation. And I can't tell you how many times the physician says one thing and I start negotiating. What about this and what about that, and can we do this test, or maybe this, and I direct the movement in a different, or the process in a different direction. That seems, because I know the patient much better than the doctor can often, and they have so little time to make decisions. And if I know the patient, I know how they think and how the family thinks and what's important to them. And also we talk about the appointment beforehand. What do you need answered? And I will ask the questions for the patient, and I will ask them insistently. If I don't get an answer, I will ask again. I'm not shy. I'm very polite, but I'm persistent. And until I have the answer, even the patient doesn't understand at the moment, we'll walk out, and then I'll explain. And then I explain to the family what happened. And so at key appointments, it's so important to have somebody there.
I would just add, for seniors, this is especially important to have, because doctors just tend to speak down to seniors as if they can't understand anything. Or one thing that we watch for as advocates, though, is we don't want the doctor to start speaking only to us and ignoring the actual senior patient.
Right, sure.
So our job is to make sure the senior patient is also involved. But
absolutely, yeah.
And if we get to the hospital discussion, I mean, seniors are at the bottom of the food chain in a hospital. And so in that way, it's super important to have an advocate and have those skills.
I've got some questions related to that on the hospital that have come in, but before we dive into that, and I really want to dive into that, let's kind of go through some of the governing bodies, and I've got some of these that I can pull up on the screen. Would you like to walk through the different associations and the certifications that patient advocates may be able to utilize?
So I'll talk about the three associations, and then Lea can talk about the Patient Advocate Certification Board, which offers the only nationally recognized credential. But the three main, the first one is the National Association of Healthcare you've got Alliance of Professional Health Advocates. Okay. Yeah. That was started in 2009 by a woman named Tricia Torrey. It has a related advocate directory called Advo Connection, like the first four letters of advocate, Advo Connection. And that's where you can do a search for an advocate, either geographically or by specialty. The Alliance focuses more on helping people who want to start a business and to run a business. So Trisha's main focus is the business side of creating this and nurturing and growing this profession. The second organization, also started in 2009, is the National Association of Healthcare Advocacy. And I was a founding member of that with Joanna Smith, who actually stood it up in 2009 in Berkeley, California. I also became president, vice president, bottle washer, but that is our professional association where, you know, its focus is mostly on education. Education for people doing the work, education for the public. It's a 501c3, so there's a public component where people can go to watch webinars and learn more about how to become their own best advocates. And then the third main national group is called Health Advocate X. There it is. That is a rebrand of a group that's been stood up since 2012 in Washington State, which at that time was just for Washington State advocates, but they've gone national now, and it's Health Advocate X. Both NAC and Health Advocate X and Advo Connection, all three have directories where you can search for advocates. Health Advocate X also is a nonprofit, and so it also offers a lot of educational materials for the public. In the past year, they've been doing remarkable work on COVID, bringing in amazing speakers, you know, a real outreach to the public. So those are the three main national associations. And again, just to remind people that, you know, this is a new thing. I mean, these associations began in 2009. And so to be where we are is a testament to how many people have dedicated themselves to making sure people don't get lost in our healthcare system and achieve better outcomes.
Yeah, it's you're pioneers. And I remember the beginning of the care management movement, the senior management movement,
Yep.
the daily money management, but it's great that you've got these various organizational bodies, you know, that are keeping the ethics in check and
Yes.
And what have you. And I guess, Lea, you're going to talk about, you've got a certification board.
Right. This is the first certification for patient advocates nationwide. They have certain educational requirements, which keep changing and increasing, I think, recently. They have an exam twice a year, and you have to subscribe to a code of ethics, obviously, and very much know about the system, but also know your boundaries, which is very important in patient advocacy, to know how far you can go. I have the medical knowledge. I'm not a licensed physician. I do not diagnose or treat, and have to know my boundary very much. And so they give a certification for 3 years, and then one has to do continuing education. So they're trying to, you know, make it a standard of education, a minimum standard of education for patient advocates. And on the directories, you will see people listing the certification if they have it. Most people are getting it. Some MDs don't get it.
And both of you have completed
it.
that certification. Okay,
Yes.
great.
Right.
Let's see. We're going to dive into, I got a question about hospitals, and then we can talk about how patient advocates work in hospitals. But Olive has a question.
Can I just say, before we get into hospitals, our job very much also focuses on staying out of the hospital. So that's a whole big story of how do we prevent people having to go to the hospital before you get into that situation where you have to be in the hospital. But go ahead, please.
Okay, let's see. Olive says, the patient's PCP, primary care provider, also plays an important role in the patient medical care management, even though they might have an advocate. Great statement. I don't think, and a great reminder to everybody is that it's a team, and each member of the team is doing something different.
Yeah,
well, that's completely true. And unfortunately, the reality is that PCPs are always super busy, and the majority have now, well, in the DC area, I can't speak for the country. Locally, it's very hard to find a primary care who is not part of a concierge practice. And they've gone into concierge so that they have time to quarterback the patient's care. And so, of course, they're the central component, but they don't always have time to, call and see if this test has been sent over to this specialist, for example.
Right.
I've, out of curiosity, and I bet you there's people in the audience that are listening to this and saying, wow, this is a really interesting profession. I've got sort of a skill set that might lend me to doing this. Have you seen any medical practitioners bring on a patient advocate, or like other providers like Aging Life Care? I could see where complementary businesses might sort of hire a patient advocate to just improve the care that's being delivered to their clients.
Yeah, so I think doctors often will have a nurse in the office which does a lot of that work. But again, they're usually too busy to go as far as we go.
Okay.
Yeah.
But I could see where some innovative practices might sort of say to a nurse or hire somebody with the patient advocate credentials, depending on their client base, where it's sort of like, hey, we're gonna address this to our clients. It's going to be an additional service here, but
that would be a wonderful world.
Yeah, well, I could see it progressing. Like in the elder law world, there are some elder law practices that hire social workers that are on staff to deal with the emotional aspect of what their clients are going through. So this can be an entry point for us talking about the hospital, and then we can also talk about the pre-hospital as well. And this is Elisabeth, this is a modern day problem that we're all dealing with.
Wait, let me mute my dumb dog. Okay, yeah. I think it's done. I apologize. I couldn't find the mute button fast enough.
That's okay. And your dog is not dumb. Your dog is an animal, and we love, and she's communicating.
We love him, but yes. Not now.
Okay, so Mary McGraw says, how does upper management of the hospital react to your presence? Have there been attempts to shut you down or blank stares or anything like that? I mean, that's one question, but maybe talk about just what, maybe you've got some case examples of how you help people in the hospital. And then we can talk, as Lea said, about keeping people out of the hospital.
Do you want to go ahead, Lea?
Sure. I mean, upper management, it has to be, a serious situation, and to go to upper management. But then you're representing the patient. If the patient says you can speak for them, you're speaking for the patient, and they have no choice but dealing with you. And if you know what you're saying, there's nothing to discuss, really. Hospital stories. A simple story. 89-year-old lady wasn't feeling well. Didn't want to call 911. Called me. I came over. I felt her pulse, and she was very irregular. She wasn't looking good. So I said, "I'm sorry. We have to call the ambulance." I called the ambulance. I knew to climb into the ambulance with her, because if you don't do that, that was before COVID. They don't let you into the ER right away. you have to wait and be an outsider for a long time. So I knew to get into the ambulance with her. She had an EKG in the ambulance, which showed a very regular rhythm. We arrived at a hospital and she went back into normal sinus rhythm. So her EKG was normal again, but as such an older lady came in, we had to check out what had happened. So she had blood tests and they wanted to keep her overnight for observation. Everything checked out fine. She didn't have a heart attack, nothing. She was stable. Next morning, I come in, the new attending on the floor looks at this very old, fragile lady in bed and thinks, oh my, we have to really check her out before we send her home because, if we miss something, we'll be liable. And so I'm asking, what are we doing? We're waiting for the cardiology consult, and then we're waiting for the endocrinology consult. And I'm thinking, this is a very active, healthy lady, which he doesn't know. Nothing was found to be wrong with her. If she stays here longer, she will most likely catch something, lying in bed, waiting for an infection to come. So I asked the attending, can she see her own cardiologist tomorrow? Yeah. And the endocrinologist, we can schedule that as an outpatient too? Yeah. So could she go home now? Yeah. So our discharge was initiated. I'm looking at her papers and I know tomorrow what will the cardiologist want? To see that one EKG from the ambulance. That's the only thing that's of interest to the cardiologist. And I'm looking through the papers, there are lots of EKGs, but not that one. And nobody's aware that there's something missing. So I went back to the ER. I asked for the EKG and they found it. There it was. They just pulled it out of somewhere. So I put it in the discharge paper and I arranged the cardiology appointment for the next day and she was fine and off she went back into her life. So this is somebody who would have stayed in the hospital and maybe they would have found something and then she would have caught something from the inactivity, and once the dominoes start falling, you don't want to get there. So that's a very simplified hospital story. Another more chronic story I had with another gentleman who had a megacolon. That's part of his large bowel was very large, very distended, but it's been like that for years and years. But if a new surgeon came up on that and didn't know this history, he would think it's an emergency. So every time this gentleman who had a stroke had to go to the emergency room, I was standing there saying, no, this is normal. This is normal. This is normal. Don't touch this. That was one of the many things I had to protect him from. So in the hospital environment, the focus to me is to protect seniors from over-testing and over-treatment. Because no hospital will be sued for over-testing or over-treatment. They will be sued for under-testing and under-treatment. So never mind the financial incentive, just the legal incentive is to check everything out. And that can be too much for the older person. They don't need all of that often. Just get what you need and know when to get out and how to get out. And have the support at home when you get out. So this is discharge planning we were talking about.
Two great examples there, and we'll dive into I'm intrigued about keeping people out of the hospital, but Mike Perlman asks, and I think you mentioned this earlier, but let's just reiterate it, are your services covered by insurance? And as a follow-up to that, maybe talk a little bit about, I realize that every patient advocate bills in a different way, but sort of in general, how this is paid for.
Elizabeth, yeah.
Insurance does not pay for us, and we don't really want a relationship with insurance companies. Because, again, we stay with our clients through the entire continuum of care, wherever it goes. So it's private pay. The average, well, it depends how much the hourly rate, and most bill by hour, I think. depends on demographics, where you are, and how much experience the advocate has. So in this article I mentioned at the beginning, in the research I did, the lowest range is $50 an hour and the highest is $300 an hour. But that was someone in New York City, I think. So I'd say the average is between 150 and 200 an hour. And there are different billing softwares that people use, but it's private pay, and most of us I know do pro bono. I know I do some pro bono, and most of us I think offer a sliding scale, because I think it's safe to say most of us are not in this to get rich. We just need to pay the bills and do some good work. So I think, and most advocates did not start out being business people. So that's sort of the range of what I've heard is out there in the country.
And I will discuss it with the caller. I can give you advice and direct you, and you can do it yourself. And at important junctions, you can call me and we can discuss again directions and what your rights are, what your role should be. So encouraging, family members to advocate. You have the right, and give them free resources, like the patient advocates in the hospital, or the social workers in the hospital, or there's a patient advocacy foundation, which is free. I'm not sure how much help you can get, but they're offering tremendous things on the website.
Great.
And so that way we can keep the costs down. Or you want me to take it all on? I'll make every appointment. I'll go to every appointment. I'll in person. We can expand the help if you can afford it. So yeah.
Let's see. Okay, bunch more questions coming in, but I want to make sure we stick a pin in your talking about keeping people out of the hospitals. Tracy asks, have you ever had a situation where you disagreed with the doctor and you tried to work with this person and then you recommended to the family to switch doctors?
Yes.
Okay. Yeah, if you know somebody.
Well, yes. Actually, I just had a recent, it takes, we got to go through our little computer chips in our head to remember cases. But I had a recent one. A young woman, 37, with horrible fatigue and brain fog for 3 years after she had to have a kidney removed. Long story short, her primary care basically gave up on her and said he wasn't, even after I provided research that showed that she probably had a really bad case of anemia based on blood work and other symptoms. He was just basically done with her and said, no, I'm not going to order any of those tests, because when women talk about pain or fatigue, they're usually written off. That sounds a little cynical. I didn't mean it to sound that cynical, but it's kind of true. And so I found her a hematologist. And she said, I'm done with that primary care. I said, yes, you're done with him. He's not helping you. We found our new primary care. We found our hematologist who did indeed diagnose her with severe anemia, gave her iron infusions. And as of a couple of weeks ago, she wrote me and said, thank you so much. I have my life back. So yes, if we see that the doctors are not up to par, we will gently, because people are very attached to their doctors, exactly. We will gently suggest maybe we can find you someone else.
That's great.
Yeah. Can I give another story also?
Yeah, sure.
Great. Somebody was diagnosed with a certain type of lymphoma. He had a big lump in his stomach, in his abdomen, and was growing, and so he was at a university hospital, a local university hospital, seeing a hematologist, and she gave him the diagnosis, and here's the treatment, go sign up. And I did research on that, and I realized that the diagnosis was not done in the appropriate way. There are subtypes which are more aggressive, and they did not differentiate the subtypes. So I found a specialist in the area in lymphomas. He went there, I arranged the appointment. It was confirmed he needed a different biopsy. The pathology was done again, and he was found to have a more aggressive subtype. He got different chemotherapy, and he's doing great. So it's just stories abound.
Betty has a great question. Through the pandemic, have you found that you can do this service virtually as opposed to face-to-face?
So certainly we can advise people how to navigate for themselves. First of all, we can attend appointments on the phone. So it's better in person. It's always better in person. I've come quite far, even in the pandemic. It's always worth trying. Sometimes you can get into the room. If you can't get into the room, I've stood outside the examination room with the door open, and I was able to talk to the physician. If you can't get that far, you can sit outside and be on the phone, a smartphone, and tell the patient, you know, I tell the physician, I have a patient advocate. I want to put her on the smartphone. She can listen to you, and can you talk to her? And I've had good responses usually.
That's great.
So yeah, so there's definitely a lot we can still do. And people need it even more now as they are more reluctant to go to physicians.
Okay, let's see. Got another question that just popped in related to MOLST and POLST. The pink form, they advise to put completed forms on the refrigerator, medical order of life-sustaining treatment, and physician's order of a life-sustaining treatment. Are you familiar with these forms, and that if this has been completed, medical responders are not supposed to take you to the hospital and provide certain other treatments? You know, I'm interested in your thoughts on that, but I think this is also a good segue, Lea, to talking about how your profession might help prevent people getting into the hospital. So first on the MOLST and POLST forms.
Right, so they have to be signed by the treating physician, and they're usually completed when there is already severe health compromise in place, so somebody has advanced disease. And yes, so we need to be informed about them, obviously. And I mean, I don't know what we probably, most likely we will be the ones who suggest to the patient to have that filled out. They probably won't even know about this.
Tell us a little bit of because I looked down at the clock and we're almost to the top of the hour. So let's kind of close things out with the talking about what you had brought up earlier about, you know, patient advocates outside of the hospital.
Right. So first of all, there are millions of Americans who are solo agers. And I have one lady who is very proactive, very intelligent. She's a solo ager. She read about it and she realized who will be there to represent me in the hospital, or if I have a serious condition, who will I call on to be with me? Because nobody should be in the hospital by themselves. And so she signed me up. I have her medical records. We're in touch. If she ever has a medical emergency, she knows who to call and who will be there for her. So this is a very intelligent thing to do for solo agers who either don't have anybody who they want to burden or who is not local, to have that connection already, who know you. So we don't come into an emergency situation not knowing anything about the patient. That's one thing. The other thing is there's an older gentleman who has multiple health issues, is seeing multiple doctors on a regular basis, has ongoing issues, and he added me to his care team. So when he has a problem at 7 p.m. and he doesn't know, should I go to the emergency room? Should I not? Can this wait? Should I? And then they can call me, and now with Zoom, with FaceTime, they can even show me what they're concerned about. And I can say, you know, this is something that can wait, or I don't think that should wait. Or who should address this? Which doctor should I go to for this? Or once he called me from the ER, and I couldn't go there. If he had requested, maybe I could have, but he was advocating for himself. But I stressed what he should say, what's important to say, that he gets treated the way he needs to. So this is another puzzle that can make all the difference. I can't tell you how many times this same older lady who I went to the hospital with has an severe high blood pressure, increased high pressure at night. And I know all she needs is some TLC, and then she'll be fine and nothing happens. And otherwise, she could work herself up and go to the emergency room. And just multiple visits will get you in, if you don't need it, if they are not really there to help you. Or somebody called me, an older couple, their husband had fallen 3 days prior. They didn't want to call anybody, they didn't know, but they didn't want to go to the hospital. So 3 days later, he was able to walk, he was able to talk, he was in pain, but everything was fine. So at that point, I was able to say, you don't really need a hospital anymore. Yep. If you're still alive after 3 days, everything that could have happened has happened, and everything is, you'll heal. You can relax at home.
Okay, Steve, can I just take 60 seconds on the subject of hospitals since we're talking about staying out? Can I just point out for seniors, what are the biggest dangers for seniors in the hospital? And I will be very quick. As I said earlier, they're low on the priority. And so seniors in hospitals and rehabs definitely need a family member, a friend, someone to help manage their stay. The main risks are falls, fractures, bed sores, urinary tract infections are very common. Lea talked about futile treatments and overtreatment. That's a huge issue. Medication errors have to be, monitor carefully the medications, know why they're being given, ask about interactions. Infection, as has been mentioned, is a huge risk. Blood clots. And then confusion and delirium is a very common outcome of a hospital stay, especially an ICU stay. And adult children often get panicked. What happened? Do they have Alzheimer's? No, they just have hospital-induced confusion or delirium. So, there's some basic things that anyone, family member, friend, should really pay attention to when a senior is in the hospital.
No, that's great. Okay, we're after one, but let's address this question here. And just a reminder, I dropped contact info for both of the panel members into chat, and we're recording this. Let's see. This question says, often family members have different opinions about care and treatment. Some often want to do everything the doctor says, and the patient or senior might want. Others care not to have surgery or more invasive treatments. Can you speak about advocates helping patients learning patients' wishes? And also, are there more holistic care plans or alternatives in complementary medicine for more natural care plan advocates? Okay, I know I botched the reading of that, but in essence, we've got, different family members' viewpoints, but also those people that would prefer alternate non-invasive treatments.
I'll just go first quickly because I know we're low on time. Very common problem. There's the phenomenon of the fly-in sibling, where one sibling is the primary caretaker of an aging parent. The fly-in sibling shows up, decides everything's being done wrong, and tries to take over. Toward end of life, these questions can become very big. I think this is where an advocate's role as a diplomat and mediator is really important. We have to be, we're a neutral third party. We represent our client, but we play an important role in, and this has happened to me multiple times, in sort of making sure everyone's heard, presenting information, research, and to help in decision making. Now, hopefully, before it gets to that stage, the aging parent or the senior will have made known their wishes about end of life care, which is a different topic, but everyone should have end of life care documents ready, no matter how old you are. So I think yes, we have a role to play as mediators, as promoting constructive dialogue and trying to reach consensus. Doesn't always happen. Depends on whether the senior's competent. If the senior's not competent, that's a whole different story. But we do have that communication facilitation role. And if it works, it can do a great deal of good.
And just to say that in my mind, the senior's wishes are paramount. If somebody doesn't want treatment that's supposed to be life-saving, it's their choice. If they want to, after all the information we give them, we explain the risks. And if they refuse, that is their choice. If they want to stay home and it's gonna shorten their life, but they want to stay home, it's their choice.
Absolutely. Yeah. It has to be. And in terms of complementary, in terms of holistic, I mean, hospice is certainly a piece of that. But the complementary treatments is kind of, we'd need another conversation for that. But yeah, in the end, if and it's perfectly okay. And there's a great book I'll recommend in closing by Atul Gawande called Being Immortal. Mortal, M-O-R-T-A-L. He's a doctor at Harvard. It is the best single book on end of life and how people and the proclivity of doctors to push futile treatment at the end, way too much treatment, and how hard it is for doctors and families to let go when the senior decides, I'm done. And so I recommend that book to everyone. Gawande is Gawande. Atul is his name.
I'm putting the link on.
Great book.
I'm putting the link
should be required reading for anyone working in the senior space.
Yeah, I'm putting it in the chat there, a link to that on Amazon. Okay, one last question, I promise, and then we're going to wrap it up. Cindy asks, does your client have to sign a medical power of attorney for you to speak to their healthcare providers?
No.
Just the HIPAA forms.
Okay.
Yeah, medical power of attorney means you have the right to make decisions on their behalf. We don't.
You're just talking. Okay.
We just
it would just be the HIPAA forms that we all have to fill out every year about who the doctors are allowed to talk to.
Well, and that is an interesting question, though, is that have you ever had a client, like I can see the value in actually this being arm's length and you don't have a medical power of attorney, but are there situations where you might actually be the medical power of attorney? I can see with like a solo ager where that would be something, a role that you could play.
Right. Some patient advocates do that. Some don't. It's a big responsibility. Yeah.
No.
Yeah.
Okay.
Some do, though.
What's interesting is almost every one of our discussions brings up solo aging. And Leah, you brought it up. Next week, we have a discussion 100% dedicated to solo aging. So I'm really looking forward to that. Well, thank you. No surprise that this was a very interactive and thought-provoking discussion. I'm glad that we can have helped get the word out about this important profession. I really appreciate the two of you joining us, and I really thank our audience for asking such wonderful questions and engaging with us. And thanks again, and we'll see everybody next week.
Thank you.
Thanks everyone for joining in. Thank you.